Now, moving on to the regional survey in cerebral palsy. As it's a kind of a disease which affects right from almost every joint, it can affect your spine, it can affect the neck muscles, it can affect shoulder, elbow, hand, and then way down into the hip, knee, ankle, everything. So, we need to assess each and every joint, analyze what is the wrong with it, and how we can deal with it. So in this section, we will be going through how to regional survey of the cerebral palsy, those patients, how to analyze these patients who are suffering from cerebral palsy. So we start from the hand and the finger anomalies. This could be in the upper limb, could be elbow flexion deformity, which is most commonly usually the forearm is pronated and elbow is flexed, and there is associated with fixed flexion deformity. If elbow cannot relax, then if the patient is able to extend his or her elbow, that means there's no contracture and no treatment is required. But if there is a fixed flexion deformity of the elbow, then it can be dealt with either fractional lengthening of the bicep and brachialis tendon. Now, other options in the wrist, this could be in the forearm, could be pronated forearm. They are usually associated with fixed flexion pronation as well. And this is fairly common, associated with subluxation of the really head, and release of the pronated teres is sometimes required so that the forearm can be supinated. Then coming to the wrist joint, then usually involves, if you see it over here, there's flexion deformity with botanier deformity, and sometimes the classical representation of a thumb in the palm. This usually children have a fixed flexion at the wrist joint with thumb in the palm and kind of associated botany or swan-neck deformities of the tendon. Then depending upon how much severity it is, then it has to be dealt with. If the thumb is in the palm, then the patient will not be able to use his hand because there will be no pinch function and grip function. So therefore that has to be released out of the palm so that they can use their thumb properly. Now coming to the further upper limb deformities in fingers, sometimes it includes flexion deformity, which may be usually single finger, or there may be multiple fingers involving. Spasticity may give rise to clawing. Selective mode neurectomy may be helpful but not always. And as there is increased flexion contractures, flexor tendon release or lengthening may have to be done so that they can extend their fingers properly. As I told you, there is always thumb in the palm deformity, and that has to be treated because if thumb would stay in the palm, then they will not be able to have a pinch and grip function. So it's usually due to spasticity of the thumb adductors and flexors, contractures of flexus pollicis longus, and usually the treatment is always the lengthening of the flexor pollicis longus so that the patient, as you can see it in this diagram, is able to extend and abduct his or her thumb. Now coming to the lower limb, if lower limb is affected, usually it's whether hemiplegia, diplegia, total body involvement, usually the lower limb is always affected. And that includes, if in case of a unilateral cerebral palsy, it's mainly only the foot and ankle, hip and knee, and LLD or ligament discrepancy. But if it's bilateral, this may be associated with hip adduction and flexion deformity, hip internal rotation deformity, hip subluxation, knee flexion and extension deformity, and external tibial torsion. So depending upon whether it's unilateral or bilateral, we have to assess hip, knee, foot and ankle, and tibia for bony and soft tissue abnormalities. So in case if it's a unilateral cerebral palsy, we have its 4 subtypes, which have to, depending upon what kind of abnormality it is in the foot and ankle. So in a foot and ankle, usually it's equinovarus deformity, that foot is in equinus and in varus. There is associated with weak tibialis anterior. The active plantar flexion is actually required, and lengthening of the gastrosoleus complex may be needed as well so that the equinus can be corrected. And this usually 2 ways of it. You can lengthen the gastrosoleus complex or form recession, but recession is better than the lengthening of these muscles. Then there's dynamic varus deformity, that when child walks, the foot goes into the varus. This could be treated by splint because it's flexible. Tibialis anterior and posterior tendon transfers can be done as well, because usually tibialis anterior is weak, therefore tibialis posterior is transferred instead of tibialis anterior. Or muscle lengthening osteotomies can be done as well. The bone is osteomized and then muscle lengthening procedures can be done. Other is pes planovalgus, that is usually flat foot deformity maybe as well. This usually requires subtalar arthrodesis because these patients usually have subtalar instability. Maybe tendon lengthening may be helpful, but sometimes if you're done with the arthrodesis, then probably most of the time the problem is corrected. If the child presents with a bilateral cerebral palsy, as I told you, there will be increased problems with the hip joint. There will be usually hip adduction contractures, flexion deformities, and depending upon what kind of equinus is present. Mainstay is physiotherapy. We give, if it's flexible, the first and foremost treatment is physiotherapy of the hip, knee, and ankle. Then it could be use of ankle foot orthosis or AFOS, depending upon what kind of a problem it is. Then maybe surgery may be needed as well in the form of adductor release, contracture release, or even hamstring lengthening or recession procedures. Depending upon what kind of problem is there, different AFOs can also be used. If you see this diagram where there is a true equinus, only the foot is in the plantigrade position in this usually alpha angle, which is calculated by the long axis of tibia and the long axis of the foot. There is usually greater than 90 degree. For that we give hinged AFO. If there is flexion contracture of the knee, this usually associated with gastroc hamstring recession. Actually, the problem is gastrosoleus hamstring both are tight, leading to knee flexion as well as equinus. Although angle is greater than 90, but we can also give hinged AFO. If the problem is in case of apparent equinus, in which although the foot looks like an equinus, but usually the problem is somewhere in the hip and the knee, then for that solid AFO can be given as well. If the foot is in plantigrade, that is angle is less than 90, but the problem is that when the child walks, due to tight hamstrings over here, the knee joint and flexion contraction of the knee joint, the foot goes into equinus. Therefore, we don't need to do something over here. The problem lies over here. So addressing the hamstrings and tightness, their tightness is also important, along with giving GRAFO. That is another form of AFOs can be given. Now coming to the hip adduction and flexion deformity. Usually with bilateral cerebral palsy, it's very common deformity. Hip is adducted. If you see it over here, this could be unilateral, bilateral, that it's adducted, that is inside internally rotated. And usually that is why these children usually present with a scissoring gait, that one leg is actually crossing over the other leg. As I just told you, it's associated with internal rotation and increased hip thigh problems. This can be corrected in form of adductor release, because the pull of adductors is decreased, therefore some kind of external rotation can happen at the hip joint. There may be open tenotomy of the adductor longus or gracilis division, or this could be done percutaneously, depending upon how much problem is there. There could also be neurectomy of obturator nerve, which actually supplies the adductor compartment. Therefore, these must undergo paralysis and hypotonia, leading to decrease adduction and internal rotation at the hip joint, thereby correcting the scissoring gait. Other is hip flexion deformity. This hip may be in a flexion as well, associated with fixed knee flexion, or the knee may be normal but there are only associated contractions of the hip. There may be hyperextension of the lumbar spine, because now hip and knee are in flexed position. That would kind of increase loads of the pelvis in such a way that there will be hyperextension of the lumbar spine. Operative treatment usually is done to release the hip and knee of the contractures, along with the correction of the hyperextensive lumbar spine. This may be associated with the lengthening of iliopsoas tendon, which is actually causing the flexion deformity at the hip joint. Or psoas release may be done at the lesser truncator level or at the lumbar spine level. Or the knee contractures can be done with simply hamstring lengthening. Now coming to hip internal rotation deformity. If you see this is normally in case of tibia usually externally rotated, but if it's internally rotated, then instead of foot coming like this, that would come like this. And if the patient is walking instead in an external rotated foot portion, instead of these toes going in, they will start going out. So it's inward and outward toeing gait is there associated with internal and external rotation of the hip. Adductor release and psoas lengthening actually not only helps in flexion and adduction, but also causes the adjustment of the internal rotation of the hip joint as well. Usually medial hamstring lengthening is enough to cause clear the knee of the contracture, and derotation osteotomy, although rarely required, but can also be done if despite all this soft tissue releases, the internal rotation is so much that it's still not normal. Then derotation osteotomy of the femur can be done so that this patient is able to walk properly, where there is no in-toeing and out-toeing of the toes. Now coming to the hip subluxation. As this, if you see this diagram, usually the hip is internally rotated, adducted, and therefore it predisposes to posterior subluxation. Hip may be in posterior subluxation, or there could be a frank posterior dislocation as well. So in 30% of the children, this is usually present. Femoral nerve is in anteversion and results not remodeled. There is flexion, adduction deformities. There is risk of joint subluxation, and stabular dysplasia is always present. In these, usually the main aim is to prevent subluxation. This could be done in form of either release of contractures so that this hip is actually coming back, or if the child has now grown old enough that the hip replacement can be done, maybe at the later stage of the life, hip replacement is quite a reasonable option, but not early on. We may have to resort to orthodesis because early on hip replacement will wear off quite quickly. Coming to the knee deformities, as I told you, they're usually associated with flexion deformities due to hamstring tightness. This is aggravated by hip flexion or weakness. We have to go for the gait analysis in these and see whether the hamstrings are only tight or whether there's also associated tightness of gastrosoleus complex as well. And sometimes the treatment would include only the capsular release, that the release of capsule would resolve the knee flexion contractures. If it's not resolving, then we may have to go for the hamstring lengthening procedures or recession procedures so that the correction can be done. But if the fractional hamstring lengthening and capsule release, all the soft tissue procedures is not helpful, then we may have to go for semimembranous lengthening, or if still not helpful, then probably to resolve the knee or the fixed flexion contracture, we may have to go for some kind of a extension osteotomy at the distal femur. As I just told you, if all the soft tissue procedures are unable to completely rectify the fixed flexion deformity in the knee, then the next option is a bony procedure, which forms as a extension osteotomy with the wedges taken out anteriorly. And once with joints, these two are joined by a form of a plate, this results in hyperextension of the knee joint, leading to correction of the fixed flexion deformity of the knee. This could be once the osteotomy is done, then it could be physeal plating can be done. This anterior shortening of the femur sometimes is also helpful, or reefing procedure is also helpful, and there may be associated not only gastrocnemius tightness, hamstrings, and all this has to be released along with lengthening of the gastrosoleus Achilles tendon as well. In this section, we have gone through what are the different regional may be involved, depending upon whether the hip is in adducted, flexed, and the contracture is present or not. We may have to go for certain kind of a surgical procedure so that the hip flexion, adduction, internal rotation deformity can be corrected. Usually, knee presents with a flexion deformity that has to be corrected as well. In the upper limb, usually the thumb and the palm deformity has to be corrected. Flexion deformity at the wrist joint, flexion deformity of the fingers can be corrected in form of tendon lengthening. Pronation of the forearm can be corrected by release of pronator teres, and elbow flexion deformity can be corrected by either release or recession of the bicipital aponeurosis. That's all from this section. Thank you very much.